Hello, my name is Jasmin Martinez. I will be presenting my case study for our clinical rotations in the fall. My patient was a female, 60 years old. She was 5'5" and weighed about 201 pounds. The chief complaint was she had severe abdominal pain, and her admitting diagnosis was perforated bowel and sepsis. The patient's story was she was admitted for abdominal pain that she had been feeling for a few days. They took her in to do an exploratory laparotomy just to kind of see what was going on in there, where they discovered that she did have a perforated bowel, which they did a sigmoidectomy. She remained intubated and was taken to the ICU. The patient started to show signs of developing sepsis. Because she did have a perforated bowel, it did put her more at risk for developing a more systemic infection, just like sepsis. The patient's family did not want for the patient to remain intubated for long and pushed for the patient to be extubated immediately for fear that she might die on it. I do believe the patient's boyfriend had a situation where their mother was very ill. She was put on a ventilator and then she passed away. So there were ties of him making these connections with the patient being on the ventilator, and the more time she stayed on the ventilator, the more probable it would be for her to die on it. Once the patient was extubated, she was very confused. She was aggressive, agitated, and she had to get reintubated. It was just very hard to take care of her, seeing as to how she did rip out her art line. She took out her Foley. She was very combative. She was not very happy about having her BiPAP mask on, which she really did need just because of her O2 increased needs. The patient does have a history of coronary artery disease. She does have COPD and she is a current smoker. Smokes about 75% of a pack a day for the past 42 years. She does have allergic rhinitis and she is not compliant with her OSA. So these are the assessments that were made while she was intubated versus extubated. For the most part, her skin color did stay flush. She was red around the cheeks and her extremities were warm to the touch as well. She was using accessory muscles more when she was extubated just because she was very combative and agitated. She was not diaphoretic when she was intubated, but she did become diaphoretic while she was on the BiPAP just because of her increased needs. Her breathing was regular while she was intubated, but then while on her BiPAP, they became shallow and rapid. Chest expansion was symmetrical, and she did not have any edema. Her vital signs, again, this is while intubated versus extubated. Her heart rate was 92 while she was intubated, and it increased to 110. It was kind of a range. It would go from upper 90s to all the way to almost 120. Her respiration rates while she was intubated, she just kind of rode the vent at a rate of 18. And while extubated, she was ranging from high 20s to mid 30s, just kind of a high respiration rate there. Her SpO2 while intubated was about 91, and that was, I believe, on 40%. While she was extubated, she was in a range from mid 80s to 90s, and that was while she was on the BiPAP at 90%. Her blood pressure was 108/67, and then kind of in between there, her blood pressure kind of dipped down to 84/52. Her temperature was 98.9, and then it kind of increased a little bit the next day to 99.9. Her lung sounds were pretty much clear and diminished in the lower bilateral lobes, And the next day, while I auscultated her, you could start to hear some rhonchi and still diminished in the lower lobes as well. So the anatomical alterations, what I could gather was she did have atelectasis. So atelectasis, partial or total collapse of the alveoli and primary lobes. Can be micro atelectasis or subsegmental atelectasis, which is the most common. Lung segment is fairly common. Lung lobe is less common, and then for the entire lobe to be collapsed is rare. So, for pre-op patients with obstructive and restrictive pulmonary diseases, they are at a higher risk for atelectasis. So, it's very important to kind of assess them and just make sure that you monitor them. Bedside spirometry, where you can get a vital capacity and inspiratory capacity, could be an early detection of atelectasis. For patients that already have atelectasis, one of the things that you could do is treat the underlying conditions, which could be giving them pain meds to kind of control their pain, control and treatment of airway secretions, so making sure that their airways are patent, and then corrections of inadequate tidal volumes on a ventilator. Also, it's good to check and see if the ET is positioned right. And if not, just making sure that it's out of the right main stem bronchus, or withdrawing air or fluid from the pleural cavities could also be something that you could look for. Anatomical alterations that we kind of saw just with the auscultations and also some lab work, you could see that the patient was developing pneumonia. Basically, pneumonia, the alterations for there is just the inflammation of the alveoli, alveolar consolidation, and atelectasis. So here are her lab results. You can see that the white blood count is a little bit high. It's not too high, but it had increased significantly from her past one. Her hemoglobin and her platelets are low, and that can just kind of correlate back to her having surgery. Her procalcitonin was 18.28, which is considered high, and this is a big indicator that the patient does have sepsis. Her bun and creatine were pretty much normal. Her glucose was a little high. Blood cultures indicated that she had gram-negative rods in it, which goes back to the sepsis. And then when she was reintubated, her ABG was 7.46, 27, 73, and 19 on the vent with 60%. The respiratory medications that she took was Duoneb Q6 with Dulera 2 puffs BID, and at home she had a regimen of Symbicort 2 puffs BID and Duoneb Q6. Some of the non-respiratory medications that she was on was she had propofol, levo, fentanyl, and then Precedex, which she moved from the propofol to the Precedex once they were extubating her. Another few medications that she would also be on that I was not there once they put her on these were probably some antibiotics, just to kind of help out with the sepsis and the pneumonia. The MD interpretation was that the patient had hazy bacillar lung opacities with no pneumothorax. The heart was mildly enlarged with normal vasculature. You could definitely see the outline of her heart just being a little bit bigger than what you would probably see on a normal patient, which goes back to the patient having coronary artery disease. And then in our book, it says that lobar pneumonia is widespread or diffused alveolar inflammation and consolidation confined to one or more lobes of the lungs. And for her, it was both lungs were starting to kind of develop that consolidation, and it was more diffused. So some connections that we could make was worsening X-rays and elevated white blood count along with the rhonchi could indicate that the patient was developing pneumonia. The chest X-ray also showed that the heart was mildly enlarged, which correlates again with the patient having history of CAD. Low hemoglobin and low red blood cells are due to the perforated bowels and the surgeries that the patient had. And then the elevated procalcitonin was due to the patient having sepsis due to the perforated bowel. While she was intubated, she did have a high glucose, which that could go back to her tube feedings, or sometimes glucose kind of rises with some signs of infection as well. So some suggestions for this patient. The first one being is that we extubate when it is appropriate for the patient. Since this patient was extubated earlier than what was recommended per family request, since we had to re-intubate the patient, just making sure that we are extubating her with appropriate parameters and with her condition improving. Also making sure that we keep the vents clean. We make sure that we keep her circuit closed so she does not develop any other infections. Auscultating the patient, making sure that the patient is getting suction appropriately as well. Monitoring her vital signs and her lab results. Also, since the patient did rip out her art line, making sure that we put another one in just to make sure that we're getting some adequate readings and we can go ahead and give her blood pressure medications if need be. Once the patient is better, some suggestions for that would be continuing her meds to maintain her COPD, as well as educating the patient on being compliant with OSA and the benefits of being compliant with that. So some of the outcomes for this patient is that now that she is reintubated, she can get a little bit more time to recover from her disease processes. Just because she did have surgery and she did become septic and she is developing pneumonia, it's very important to actually give the patient some time to recover, especially because just battling at least one of those can be very hard on the body. Because this patient doesn't really have much history of complications or anything, I could see her just, once she has recovered from all of this, just being able to start ambulating, making sure that we start probably some incentive spirometry or some easy pap with her just to keep atelectasis from reoccurring is also going to be very beneficial for this patient. Another thing that would benefit this patient's outcome would just be re-educating the patient on taking their medications for COPD. So instructing them that once they get home, making sure that they continue taking their Symbicort and their Duoneb, as well as also educating the person on OSA, just in case if they want to be a little bit more compliant, trying to tell them the benefits of actually being compliant with their OSA, such as adding a CPAP at night, and if they need to doing a sleep study to see what kind of equipment they need and their settings for CPAP if that's what they were needing. And then also making sure that the patient knows to keep their incision clean, making sure that if they're taking any steroids, corticosteroids orally, to make sure that the patient knows to rinse out their mouth just so they don't get that yeast infection. And then also telling the patient the importance of ambulating and not sitting for too long, even though it might be painful, just instructing them to be a little bit active walking around just to make sure that they don't get that atelectasis.